And now it's time to move on to our plenary panel. The title here is The Role of Economics in Shaping the ACA and How Economics Can Inform the Inevitable Mid-Course Corrections. So our plan is to have our panelists, who I'll introduce in a moment, speak for about 15 minutes about their thoughts on that topic. And then we're going to open it up broadly to questions from you folks and get their responses to those questions. And so our speakers are Mark Pauly and John Gruber. I think you know both of them. Mark is the Benheim Professor of Healthcare Management here at Wharton. He's the Victor R. Fuchs Lifetime Achievement Award winner for AHEC in 2012. Mark has published hundreds of articles. Hundreds of articles.
With thousands of words.
With thousands of words. Including several of the most seminal papers in health economics. And in my view, no economist has had a longer, more sustained impact on health policy than Mark Pauly. John Gruber is the professor of economics at MIT. He received the AHEC inaugural medal for best, this is not a very short title for an award, best health economist under the age of 40. He has published over 140 articles, edited 6 volumes, and is the author of Healthcare Reform, a graphic novel. John's contributions to the ACA are very well documented. He's one of the architects of the Massachusetts reforms, which was instrumental in the ACA design. And he has received the high and distinct honor of being disparaged by Bill O'Reilly on Fox News. And so to start, we're going to start, Mark is going to give his thoughts, and then John is going to give his.
So a little bit of the planning behind this, we thought that we could hardly have a plenary that didn't talk about the ACA, so the ACA had to be the subject. But we did not want to just have whoever was going to be on the plenary give their views about the ACA. For one thing, I don't know about you, but I'm swamped with talking heads doing that. And for another thing, speaking of the aforementioned AHEC, we had a session with John Gruber and Steve Parenti doing that last year, and I don't do a very good Steve Parenti impression. So I thought I didn't want to rerun that. So our thought was to begin at least by talking more dispassionately about the contribution that economists made, or in some cases perhaps didn't, to the design of the ACA and of features in the ACA. So that's sort of the do bill here. Now, I guess having said all that, I'm a red-blooded American person. I have views on the ACA, and I wanted to put 2 of them on my sleeve at first. One is, somewhat to my surprise, when I was asked by a reporter, do you support the ACA compared to the status quo? I said yes. Then as the reporter ran away, I said, but there's a lot of things I would change. But I compared to the alternative, I'm glad we have the ACA. The second is my kids wanted to print up T-shirts for me on Father's Day that said, Father of the Individual Mandate. I discouraged that again because I wanted to put a footnote that said, but not necessarily this individual mandate. But if I had the T-shirt, I'd wear it with pride. I'm going to talk about 4 things. Contributions that I think economics made to the design of the ACA. Second, changes I would propose to the ACA if tenured economists were in charge. A third, politic changes, which is going to be a much shorter list. And then finally, what I think is the most needed research for proposing changes and improving the ACA going forward. So, okay, so it probably comes to no surprise that tops on my list is the Cadillac tax. Somewhat to my surprise, but great pleasure, the idea that the current tax exclusion for employment-based health insurance distorts the health insurance choices of better off Americans, or at least non-poor Americans who are employees, is one that I and a lot of economists have been preaching for years. And as I said, I was surprised, but also delighted to see that at least a remnant of it survived into the final version of the ACA. That's a good reason. I plan to stay around until 2018 just to see that, if nothing else, because I think it's going to be important. Now, I do have to say, of course, I'm an economist, so on the other hand, it's not my version of exactly how to deal with the tax exclusion and the tax subsidy. I would have preferred, as I suspect many of you would, to if not totally eliminate, at least cap the exclusion. The reason why it took the form that it did, in part it was politics, that's the reason for everything, but in part because the president had promised not to levy taxes on the middle class, so levying them on insurers obviously was not the same as levying taxes on the middle class. It took Chief Justice Roberts actually to levy a tax on the middle class as part of the ACA when he characterized the penalty for violating the individual mandate as a tax, which will fall on the middle class. But even so, having said all that, if I were to improve it, and I think cue the theme music from Jaws, there are a lot of people who are worried about it, trying to think of changing it. I would make it look more like an exclusion, a limit on the exclusion, which would have the positive effect of imposing smaller penalties on lower wage people than on high wage people. Uwe Reinhardt says he sends a Christmas card to the Treasury every year thanking them for his tax breaks. I don't do that, but I could. And I also think whatever the cap is, it's within the realm of human ingenuity to figure out how to risk adjust it so we don't have those problems. But I'm hoping it's going forward. Maybe not. It's conceivable that if healthcare spending growth continues to slacken, maybe we won't hit those limits, although I think we will eventually. But either way, I'd be happy. The second is back to the individual mandate. I do think the individual mandate is a necessary component of a wise health reform proposal for two reasons. One that's been much remarked in the literature, although personally I think is less important in my own lexicon, to be the glue that keeps the system together when you've imposed community rating. The other is to round up the stragglers, even without community rating, with risk rating. My guess is there's 4 to 5% of the population that, like us, doesn't get up every morning and think about having health insurance, and they need at least a push in the direction of getting health insurance. And our individual mandate was a Rambo mandate, where the penalty essentially was what your minimum premium for the minimum coverage would have been. So we collect your penalty, and unless you're Amish and believe it shows mistrust in God, you'd have insurance anyway. The third thing that I think contributed, although maybe it's just common sense, so my PhD thesis was on public and private financing of medical care, mixed public and private financing of medical care. I'm still rewriting it. I tell my PhD students, no, I go ballistic when they say they want to write a 3-essay thesis. I tell them you'll never build on that. You need something more substantial. But in addition to moral hazard, which was actually a little distraction in that magnum opus, I basically proposed means-tested subsidies for means-tested coverage. Subsidies that go down as your income goes up. For minimum coverage, it goes down as your income goes up, and the ACA took that form. I'm not going to attribute causation here, but the correlation is at least heartwarming. A third, second last thing is the the subsidy pattern in the exchanges at least has predetermined subsidies in the short run, so you will pay the incremental premium from going from bronze to gold, from bronze to silver to gold, which is ideal. And then there's a good bit of flexibility on minimum coverage, which I think economists would have also suggested, because people have different preferences about what coverage they most like, and especially if you want to get people to be insured, why not, at least within broad limits, let them choose the insurance that most motivates them to be insured, as opposed to the insurance I would choose for them if I were planning everybody's life. Okay, so that's the contributions. The changes I would propose if tenured economists were in charge. Well, I've already commented on this briefly in the little piece that Adam and Levy and I wrote for the New England Journal. I would actually remove the employer penalty permanently and convert the subsidy into a uniform lump sum subsidy based on income, regardless of how you get your insurance. I know that causes problems with target efficiency, because you'd be substituting public money for private money for low-wage people who work for large firms who were, at least according to us, presumably mostly paying for it themselves. But for one thing, I think that's more equitable, and for another thing, it would remove these distortions that everybody's talking about, employers dropping coverage and moving people around. If the subsidy was independent of how you got your insurance, at least there would be no more distortions. More transparent financing. So again, this had to do, I think, with the political character of this. But if an economist, or at least if I thought of how to propose health reform, I would have said, okay, so roughly speaking, I calculate my incremental tax for the kinds of subsidies in the ACA is going to come to about $2,000 or $3,000 a year. I regard that as a bargain for a clean conscience, because now I don't have to worry about people underusing beneficial medical care. I'd vote it up or down. I'd vote it up. I hope the majority of Americans would. And then once it was there, there'd be no reason to change it, and no reason to hold the government hostage to change it because of the backdoor way that it was financed. And then finally, I know you're waiting for this, community rating is the world's dumbest way to do a good thing. The good thing that we want to do is to help out high-risk people, both for equity reasons and possibly for some kind of argument about smoothing, protecting people from reclassification risk. And of course, that even doing that has downsides of its own, because it offers people incentives to wait to get coverage, even with the relatively modest penalty, until they really need it. But the big distortion is financing that subsidy by effectively an excise tax on health insurance purchased by low-risk people. And I wrote a paper in 1970 called The Inefficiency of Community Rating, and I still think it's terribly inefficient. I know if you are willing to make some assumptions about differences in demand elasticities, you could make it look a little less inefficient, but compared to the alternative, which I would have favored, which is a general revenue financed contribution to high-risk pool in the short run, and tilting at windmills, guaranteed renewability, mandatory in the long run. This just seems to me to be a dumb way to do things. It's caused so much consternation. I still don't think that Armageddon is at hand, even so, because I think the amount of adverse selection is likely to be handleable, although not necessarily desirable, but I think it's a problem. Politic changes, what I would do is increase the penalties for waiting to get coverage much more. I would actually, this comes from having raised 3 children, I guess. I would really want to get really tough on them if they didn't buy health insurance in 1 year, and have really high and escalating penalties in the following year. And eventually they'd be grounded, or whatever it would take to get them to buy health insurance. And then secondly, I think it's worth thinking about having not only competition among health insurance plans and exchanges, but also competition among exchanges. Why does there have to be just one exchange? Why can't there be multiple exchanges, like there are multiple insurance brokers that I could choose from if I'm going to be in that market? My last comment is on most needed research, and here I'm going to ask you to cheer me up. So the premise, actually, for my thesis work on why we ought to subsidize health insurance was this idea that we, what I would call now benevolent moral hazard. We want to create moral hazard to get people who underuse medical care by community standards to use it because it'll improve their health. And at least I was terribly depressed by the results from the Oregon study, where the impacts on health were minimal, and the moral hazard, though, came through like gangbusters. It's still about a 33% increase. And one study doesn't prove anything, and it was not super powered, although it was powered to detect large impacts if they'd been there. But I think we either need to figure out a more sensitive way to detect health influences, or the alternative, which some people have talked about, is say, well, it wasn't really health care we wanted, it was financial stability, which I'm willing to give $1.98 for, but I guess my concern is there's so many ways a person can go broke. Why would we particularly concentrate on subsidizing health insurance to prevent them from going broke that way? In another part of my life, I work on natural hazard insurance. Why not subsidize flood insurance? You can go broke there too. So those are the ideas. I hope either people can tell me why not to be so upset about the Oregon study, or about future research that might obtain more tub-thumping results on health improvements, because I think sooner or later somebody's going to wonder, what are we getting for all this money? And if we can say we're getting a lot of improvement in the health of people that we care about, we're in much better shape than if we say, well, it was good intentions. So, thank you.
Thank you, Mark. John?
Great. Well, yeah, I'm done. No, I don't know. I think I'll just react to what Mark said, because I don't think I have anything original to add. I mean, it's important to recognize, they call us the dismal science. There's some evidence for why, which if you poll people on what they like about the Affordable Care Act, they like everything except the 2 things we like. They like everything except the mandate and the Cadillac tax, which are the 2 things that we like. That's the part real people don't like. So, look, we have to do, I'd be remiss if I didn't do the obligatory few minutes of praise for Mark and his role in all this. He is the father of the individual mandate. He could have changed his kids' names to individual and mandate or something like that. But he's the father of it. And I also think, I look around, I'm actually on the older side of the crowd here. So probably in my economics lifetime, the two most important articles I think I read were Joe Newhouse's 1992 JEP article and Mark's 1990 JEL article on the tax exclusion, which really was the centerpiece of arguing, really bring to the fore why this is a terrible piece of policy and we need to address it. And I think it was that which motivated sort of a generation of us to make this the top of our agenda, and I think it was that hard fighting which led us to, for the first time, take it on. If you'd said to me, in 2008, which is more likely, that we'll pass a law that covers 25 million people, we'll pass a law which takes on the employer exclusion, I would have said definitely the former. There's no way we can take on the employer exclusion. The fact that we've done it even this indirect way is, I think, just a testament to the leadership Mark showed in highlighting this, and the fact that we've all followed up and really, really pushed on it. I want to react to a few things that Mark said. Let's start with the interesting point about the mandate and what role it plays more generally. I think the right way to think about this is think about three reasons why people are uninsured. One reason is affordability. One reason is sort of strategic, people relying in the emergency room. And one reason we could call sort of uninformed / they don't have time / they're lazy. So the story I always think of is in Jonathan Cohen's book, Sick. He's a story of the mother in Detroit who had to get up at 5 in the morning to go to her job. She got home at 8 at night. She knew she should go sign up for health insurance. She just never had time, and then she got cancer. And basically, the mandate's about affecting all of those groups. And we tend to think about the strategic because we're economists and that's fun. But it does affects the affordability because it makes insurance affordable for sick people. And it affects this other group, the sort of people who say, gee, I really should go do this, and now I'm going to go do it. Now that does come to the penalty, which is too small. Now the story here is, it's politics. I think a lot of my reaction to Mark's comment is going to be the politics. So what happened here is, as you know, the Senate finance bills basically became the law because, I must remember on Christmas Eve, the Senate had just passed their bill, had just passed their version, the House had passed their version. We all planned to make it work in conference. Christmas Eve, I went to it with my family. My wife said, hey, it's great, you're done. I said, yeah, the only thing to go wrong would be for a Republican won Ted Kennedy's seat, and what's the odds of that? Well, a Republican did win Ted Kennedy's seat, which meant we couldn't go to conference, so we had to basically live with the Senate finance bill. And what happened there was the Senate finance bill was a great bill with a very large mandate penalty, and the night before it was voted out of committee, Olympia Snowe, who was Republican, so didn't like anything that smelled of taxes, and Chuck Schumer, who, as far as I can tell, doesn't understand economics, got together and said, we ought to lower this mandate penalty. And so they put an amendment before the committee to lower the mandate penalty, and who's going to vote against that? It's a single amendment. So it passed, and the mandate penalty got shrunk down. So it really is unfortunately too low, and it's actually backwards. The mandate penalty ramps up. Actually, mandate penalty should ramp down, right? It should be you get shocked the first to get you in the system. Once you're in the system, we'll need the mandate penalty less. So actually the timing is backwards and the level's too small. So that's unfortunate. That's something ideally we'd change, but we never will. Coming to the Cadillac tax, that really was all about the politics. Mark talked about two forms of politics, but it was all about the politics. Actually, so once again, what happened there was we actually had Max Baucus convinced that we should do a Pauli-like cap on the employer exclusion. He was all set to pass it, and then the unions went nuts, and people went nuts, and he said, this is over. And then John Kerry, or more likely his staff, came up with this very clever idea of the Cadillac tax, which is, I would say, I guess, 70% as good as doing the right thing. So it's 70% as good in the sense that it's going to have a lot of the same effects, in the sense it's a 40% excise tax that happens to people with the highest marginal rate, so essentially offsets the exclusion. What's wrong with it is two things. One is, 40% isn't everybody's rate, and we really want to, in some sense, this is penalizing insurance. We want to level the playing field. We don't want to penalize insurance purchase. This is actually penalizing insurance purchase for lower tax rate people. But it's worse than that, because the Cadillac tax isn't deductible from corporate income. So actually it's effectively, so what that means, you have to raise the price more than 40%, so that the revenues you get, you can account for tax. And when you work out the dynamic logic, it's more than 100% tax, actually. So, I hate to speak ill of it, because it's better than nothing, but it really is not, it's not a Pauli-like removal of the exclusion. It's actually just really a ceiling. No one's going to have insurance that costs more than this, because it's more than 100% tax on insurance that costs above that level. That's not really rational. I still think it's better than nothing. I still would rather have that than have the existing system, but it's not But my hope is that as it gets to 2018 and people focus on the fact that this is really a very draconian tax, we can then reopen the discussion about doing the more rational thing. I recently did a paper for Bipartisan Policy Commission. We estimated that if you take the existing system, if you put a cap at the 80th percentile and CPI index it, you raise about $200 billion more than the Cadillac tax over the next 10 years. So basically, I think there's going to be an argument made, hopefully, for moving back towards the right Pauli-like solution, and hopefully we'll get there. Mark made a couple of comments that I do want to take issue with. One about transparency financing, and the other is about moving from community rating to risk-rated subsidies. It's just, you can't do it politically. You just literally cannot do it. Okay, transparent financing, unless I have transparent financing, also transparent spending. I mean, this bill was written in a tortured way to make sure CBO did not score the mandate as taxes. If CBO scored the mandate as taxes, the bill dies. Okay, so it's written to do that. In terms of risk-rated subsidies, if you had a law which said healthy people are going to pay in, it made explicit that healthy people pay in and sick people get money, it would not have passed. Okay, just like lack of transparency is a huge political advantage. And basically, call it the stupidity of the American voter or whatever. But basically, that was really, really critical to getting the thing to pass. And, it's the second best argument. Look, I wish Mark was right. We can make it all transparent. But I'd rather have this law than not. So it's kind of like his reporter story. There's things I wish I could change, but I'd rather have this law than not. And I think that involves some trade-offs that, we don't prefer as academic economists, but which are realistic. Let's talk also a little about Oregon. So I was one of the co-conspirators in the Oregon study. Two comments on the Oregon study. First of all, I think that there is no perfect economic study. And you have to put this in the context of a large literature which does show positive health benefits of expanding insurance, including studies that have been done in Massachusetts law, which has shown large health benefits of expanding insurance in Massachusetts, as well as all the Medicaid research that I did a long time ago and others have done. So I think this is a worrisome finding in that sense, but it does not mean we know the answer is no health effects. It just means, we're a little more uncertain than, I basically view it as raising our confidence intervals from where we were. The second thing is, and I just can't emphasize this enough, we did find huge mental health effects. And mental health is health. Okay, we tend to focus on kind of it's heart attacks or nothing. That's not true. Okay, mental health matters. Now, Mark's right. It's not clear that the right way to get to mental health is through health insurance. A lot of this wasn't Prozac. This was ending the stress people lived under. There was a 30% drop in depression. 30%. And that wasn't more Prozac. That was the fact these uninsured people lead horribly stressful lives. And we found enormous increase in happiness, enormous reductions in depression. And I think as economists, we need to broaden our concept of what insurance is about. Now, Mark is right. Once we do that, we then have to stack up insurance against other things which could have these effects. And that's fine. Let's run that. Let's run that race. But I think the fact it doesn't, and once again, we can have confidence intervals and other things. But just in general, the fact that it didn't find effects on physical health, people tend to extrapolate and say there's no effect on health. That's not true. There was huge effects on mental health, and that matters. Okay, so I think we have to keep that in mind when we discuss the Oregon effects. In terms of other changes to the law and things to keep an eye on, okay, some more sort of smaller subsets to keep an eye on. One, so I talked about the Cadillac tax, talked about the mandate. Another thing to keep an eye on is actually, once again, another political constraint. The way the law works is the subsidies people pay as a percent of income. The percent of income they pay actually ramps up over time. Basically, it's complicated, but percent of income you pay is indexed. Essentially, the percent of income you pay grows with the gap between healthcare cost growth and income growth. So if healthcare costs grow at the rate of GDP, then people at the top always pay 9.5% of their income to get subsidies, people 3 to 4 times poverty. But if the rate of healthcare cost growth exceeds GDP growth, that percent of income you pay grows. So it could be, under current projections, by 10 or 15 years from now, people aren't paying 9.5% of their income, they're paying 17% of their income. Okay, so that's sort of a bit of a time bomb hidden in this law. Now at the same time, Cadillac's tax revenues will grow enormously if that happens. So we could take that money and use it to solve this problem, but that is something to keep an eye on. The second thing to keep an eye on is cost-sharing subsidies. So low-income people, there's two forms of subsidies. There's subsidies you pay a fixed percent of income, and there's subsidies to sort of buy down your cost-sharing if you're low income. Those are very nice if you're below about 150% of poverty. They're not nearly generous enough between 150 and 300% of poverty. You're going to have people at 2 and 2.5 times poverty in $3,000 deductible plans. That's 10% of their income plus. That could be an issue, and that's something we have to keep an eye on. Another example of the horrible features of our current political system, in the law is this bizarre feature that for small businesses only, the maximum deductible is set to $2,000. Not for people, not for large businesses. Why is this? It's because Olympia Snow staffer was an idiot. And Olympia Snow staffer saw that in Massachusetts we'd done this. He said this is the national law. And Obama was desperate to have a Republican on the law. So he said, well, if it'll make Olympia Snow happy, let's put it in the bill, we'll get rid of it in conference. Well, then conference never happened, so the law actually features this weird glitch that for only small businesses, the deductible is limited to $2,000. Not indexed, just $2,000. Well, everyone agrees that's a bad idea, left and right alike, but you can't reopen the law, so we can't get rid of it. That's the kind of thing that we just need to get rid of, and hopefully someday we'll have a good enough political environment that we can do something like that. And then I think Mark's entirely right about the employer mandate. That was just political cover. I mean, it's a decent source of revenue raising. It's like $10 billion a year, so it's real money. But it really isn't central to the law. I think there's this unfortunate focus on what happens to employer-sponsored insurance. What happens to employer-sponsored insurance is irrelevant. Okay? What should matter is what happens to overall insurance coverage. We shouldn't care where people get it from. And so I think the employer mandate, and I think there's a decent chance it may eventually go away, because I think it's a source of an enormous number of political problems with the law. Let me just end with a couple last things so we keep an eye on in terms of research, thinking going forward. A bit of it self-serving. I think we need to really think about basically decision support within the exchanges. We're entering a brand new world that started with Part D and is now extending the ACA of people making choices over their health insurance plans. And as Jason and I have shown in the context of Part D, and we're hoping to show in future research, or look at in future research in the context of broader health insurance, there's a potential for people to make bad choices or inconsistent choices. And the question is, can decision support play a role in mitigating that? I think that's a really important question. And more broadly, there's just the question of exchange design. Amanda Stark and Keith Erickson have this really neat paper showing that a more standardized exchange design in Massachusetts was welfare improving. What is the optimal exchange design? So one last sort of inside baseball story. In Massachusetts, we went to, as you should all read their paper if you haven't, but we went to, after a couple of years, a standardized design where we sort of standardized the benefits. And people really liked it, and according to their paper, it was welfare improving. The problem was no small businesses were buying through the exchange. So we asked them why, and they said because the benefits were too standardized. They said you don't have all these funky options we like. So we actually have gone now for a mixed strategy, which is we have standardized benefits and another tier we call unstandardized. Kind of saying, look, if you want to take the chance of going unstandardized, go for it. We'll let you have that. But if you want to sort of not have to face those difficult decisions, we go standardized. Is that the right thing to do? Embarrassingly, I have no idea. So that's the kind of thing we need to be thinking more about. And then I think, the last thing I just emphasize is we need to be thinking more broadly, coming back to the Oregon results, health insurance in the context of overall well-being of our national enterprise. And that ultimately, that's what we care about, is the well-being of our citizenry. And we have to think about that more broadly. And I think the Oregon results, along with, Amy Finkelstein and Rob McKnight's results, showing that Medicare didn't seem to improve health, but massively improved financial security. Make us think we have to think about what's the ultimate structure of the safety net that makes sense. And maybe Mark's right. Maybe it's not health insurance. Maybe it's just, as Avik Roy said, maybe it's just money and Prozac in the water. Maybe that's where we need to be. But we need to be thinking about sort of what's the ultimate structure of the social insurance enterprise. So let me stop there.
Thanks, John. Maybe I'll give Mark a chance to respond to John's comments, and then we'll have some questions.
So I actually agree with everything that John has said. It's easy for me to offer a sermonette on this subject at this stage of my career. I think, people with tenure should say what's right. And of course, we're used to constrained optimization. So if the politicians tell us they can't do it, we can come up with something. But somewhere there ought to be the tablets of gold that say community rating's a dumb idea, and other things. I guess one other thing I'll mention is a area in economics that didn't get into the bill's discussion, as far as I know. Again, this may have had to do with the somewhat truncated nature of its passage, was in the design of insurance per se. My impression is they more or less copied Massachusetts, which more or less copied what was in the market, but given a lot of research on optimal coinsurance, some of which I think is well conceived and some of which is a little overly enthusiastic about certain things, but even so, I think there probably are insurance designs that could not only be part of a standardized package, but we don't know yet what they are, and we could actually do research to try to figure out what they are. Despite what I've said about moral hazard, full coverage above a deductible sounds like a nice, transparent policy that people ought to be offered, and in many ways, the amount of moral hazard once you cover the deductible is probably small enough that it may not make sense to have all these complicated deals after you cover the deductible, just so the coinsurance can extend further up the spending gradient. But those are just opinions. I think, and maybe it's more in our role as advisors to Consumer Reports than our role as advisors to the government, which of these policy designs really do make the most sense for most people, and can we take a bunch of them and basically say, you know, they can still offer them, but they should print them only on paper with red ink, so that nobody would buy them without a forewarning, and there'd be some favorite policies. That would be a kind of intermediate step between standardization and free-for-all that I think might be beneficial.
Let me just add one other thing I forgot to mention, which is there is an enormous amount of work and thinking on the research side that went to a conference that I ran at the NBR a couple years ago. And if you go on nbr.org//confer, and you look back a couple years, 2 years, there's a set of slides from that conference which are excellent, which lay out all the different research areas proposed by the ACA and a bunch of ideas. So if folks want to think more about research questions posed by the ACA, I urge you to go back, and if folks can't find them, let me know. I can send you the slides.
So I'll start off with the first question, then hopefully you folks will be thinking of questions on your own. And my first question is, given the federalism in the rollout, what states are you looking towards as kind of bellwethers of the overall impact of the ACA?
I think it would be very nice. You know, basically the problem with having the ACA was we always had Massachusetts as an example. Everyone's always said, oh, Massachusetts is weird and different. And we are, to some extent. So I think it will be nice. I think we're just going to see enormous state heterogeneity, much more than we anticipated when we passed the law. I think California is the clear next big bellwether. I think if it works in California, it's hard to say. It's just California's weird too, but it's big and weird at least. I think Maryland is another one. I think basically the states with the state exchanges are by and large broadly the places we want to look. And I think there's really two things you need to look at. I mean, one is, you know, I realize we're here to do economics, not politics, but just for a minute, this Medicaid expansion thing is totally insane. Okay, Mark Duggan, I think, had the quote I liked about best. He told me it's preposterously stupid that states aren't expanding Medicaid. I mean, this destroys any political economy economists have ever done in their lives. Okay, because here we have something which literally makes every single person in the state better off, and governors aren't doing it. Okay, because for poor people it's free health insurance. For the rest of the state it's billions in federal stimulus, and these guys are turning it down. And so that is one thing that the state exchange states are doing that a lot of the other states aren't. And the other is there's just a huge role for promotion and social equilibrium. It just was accepted in Massachusetts. No one protested. We ran the ads. Everyone kind of signed up. It went well. I think that'll happen in the blue states that are saying for the exchanges. It's not going to happen in the red states that aren't. And I think there's going to be huge heterogeneity as a result.
I guess I agree that we ought to pay attention to California because it's a very large country. Although their ways are not our ways, but I think it also is useful to look at kind of the other end of the spectrum. Utah comes to mind, and maybe Ohio or Indiana, somewhere in there, somewhere in the heartland, to see how it goes.
Wait, there are places between Massachusetts and California?
Yeah, I was actually struck looking at one of these maps about how many competitors there were. Versus the premiums. To also see there's a belt, the solid south, I guess. There's a belt across the south of a small number of high premium states where this is probably one of the things that may not be so. It's not state regulatory specific, it's something else. Insurers in those states must be guessing that they're going to get a lot more adverse selection. That'd be my take. Than insurers in other states. And this whole issue of, I mean, it's actually quite fascinating of Kate Bundorf and I were talking about this earlier, both agreeing, thank God I wasn't born an actuary, that if you had to come up with premiums, how would you even do it with any degree of confidence? And it seems clear that, to me, that the actuaries must have guessed differently in some states than others, or political pressures matter differently in other states, or some states, some insurers are willing to run the risk of taking a bath for a while just to be sure that they got in there in the first instance.
Actually, this raises another interesting issue we haven't talked much about, but needs more attention, which is the MLR regulations in the law,
Yeah.
which I generally opposed on basic, basic principles of basic economics, which say, which Peter Diamond taught me, which you tax the output, not the inputs. Don't regulate the inputs, tax the output. But actually, I've become more of a fan as I've thought about. And one reason I've become more of a fan is these actuaries are unbelievably conservative. And my guess is without MLR regulations, they would have just set incredibly high prices just to basically say, let's just cover our ass. But the MLR regulations, in some sense, are a bit insurance for consumers against these actuaries setting ridiculous high prices out of uncertainty. And I think we could end up seeing pretty big rebates next year to consumers, because my guess is the actuaries did go conservative based on the ones I've dealt with. And I think we could end up seeing some pretty big rebates.
All right, so let's open it up for some questions. Vivian.
I really appreciate this session because this is the most intelligent discussion I've heard about the economics behind the insurance side of the Affordable Care Act. So thanks for coming here today, and thanks for people at Penn for organizing this. I noticed that you didn't talk about the provider side, and there's debates going on. For example, people are concerned about, ACOs could lead to antitrust concerns. Whether people, there's lots of pay for performance in the ACO, and then there are plenty of economists who, are concerned about how you implement P4P. Could you comment about sort of the provider side a bit?
Well, it's actually interesting, kind of the bifurcation. Most of the provider side parts of the ACO don't apply to the private insurance side, they apply to Medicare. And there are part and parcel of the effort to somehow wring out 2/3 of the funding of the subsidies for those young people who don't deserve it out of what otherwise would have been Medicare spending. And I worry about what you're worried about, that this may provide a safe home for monopolies and quasi-monopolies, either vertical or in some cases horizontal. I also think it's interesting, and then I guess I have something here that I don't understand. I actually gave a talk last week to the healthcare alumni of Wharton on bending the cost curve, and I talked about the Cadillac tax and why I thought that was a good idea, and then I expressed my skepticism about the ability of external forces to bend the cost curve, and then I felt I had to say to the people there who work in the private sector, you may want to ask for your money back for this dinner, because all I've told you is we're going to tax your clients more and then lots of luck in terms of design. But you would think that private insurers would be experimenting a lot more with these alternative ways of paying. I know some are, and I know there's private ACOs and all of that, but relatively speaking, they've been very timid. You can see the politics. They don't want to get out ahead of Medicare and all of that, but where's greed when you need it? It would seem like there ought to be real, I don't know what I would handicap as better or worse, but I would love to see competition in alternative forms of paying doctors break out again in the private sector. We had it with HMOs, and of course they got creamed, but maybe this time Hollywood wouldn't pick on them and it would actually work.
I mean, I am amazed that the set of institutions designed to bear risk in our society are so conservative. I mean, insurance companies are just incredibly conservative institutions. They don't innovate. They're just like, they want to be bookies. They just want to take their spread off the top. They don't want to innovate. They don't want to do interesting things. And I think that that's changing some. But the problem is we have to admit we still don't know what the right answer is. I mean, the ACO model we've all fallen in love with, but I'm doing some work with Care First, the big insurer in DC, and the CEO there is a very innovative guy, hates the ACO model. He says it's just power to the hospital, so we're going to screw us. We've got to give more power to the doctors. Yep. He's got a very different model, which is sort of patients at a medical home on massive steroids with huge financial incentives for doctors all the way downstream. And so we don't know what the right answer is. I think our role as health economists is to be honest that we don't know what the answer is. We need to force politicians to be humble and be patient. Two things they're very bad at. Okay, humble, which is we don't know the right answer, and patient, which is we don't have to figure it out tomorrow. And the truth is, healthcare spending is going to go up. It's always going to go up. And if we figure it out in 5 years versus 10 years, it's not going to be the difference between the success or failure of American democracy. Okay, so I think we have to be patient and we have to be humble on figuring this out, and we have to recognize that we don't really quite know yet. And we're just going to have to spend some more time working on it.
I actually wrote a somewhat beard-stroking paper trying to say more good things about the Cadillac tax, the gist of which was well, as an economist, if you don't know what the right thing is, and if you did, you'd be a consultant, not an economist, what you ought to do is design neutral systems.
Right.
Joe Antos and Gail Walensky and I said more or less the same thing in our NEJM paper. And then once you put neutral incentives in place, and assuming there's reasonably good information, declare whatever comes out of it as ideal. And if when confronted with the paying the full incremental cost of beneficial but highly costly new technology, people still want to pay it. That's their as long as it's their money.
American way.
Now there's a problem, of course, that because of the maldistribution of income, when I choose the most lavish plan here at Penn, that tends to impose costs on others. But there's ways, I think, to at least reduce the extent of that kind of spillover.
Two quick questions. The political one for both of you. For 2 or 3 years from now, how many states will still not have expanded Medicaid? And then the second, more serious, when I talk to doctors, like in med school environments, they're all concerned about this doctor shortage when we cover these new people. And do you think that's an issue? And if so, what should we be doing about it?
I mean, on Medicaid, I am really amazed the numbers have been so low. I mean, what CBO, when the Supreme Court thing passed, CBO came up with their prediction, which was that within like the first couple years, half the states or half the population would be in states that adopted, and within 10 years it'd be 5/6. And I thought, you're crazy, it'll be way higher than that. And now I just don't know. I mean, literally, our models of political economy are just out the window. We have no way of knowing what these guys are going to do. So I literally don't know how long. I just don't know why someone can't run for the governor of Florida and say, look, I hate gays, I love guns, but I'm not turning down $2 billion a year from the federal government. You know, I mean, like, I just don't understand why that's just not a winning position. So I think we have no ability to predict. I mean, in terms of doctors and the supply issue, there's already a huge shortage. I mean, the evidence from Massachusetts, to the extent we have any, is it didn't get any worse. It was already bad. You had to wait 100 days before, you have to wait 100 days after to see your primary care doc. I think that's just a deeper issue. That there's a whole title of the bill on physician supply that is a bunch of tiny things around the edges about loan forgiveness and reallocation of this and that. But it's more fundamentally about, you know, our disjointed payment system, which overpays specialists and underpays primary care docs. And I think that's sort of a deeper issue the law just doesn't go after.
Just one comment on the Medicaid part. So I do talk to some of the people who said no, and I don't agree with them, but they're afraid of the pig in the poke problem, that if we sign on, X years from now, the feds will be telling us one way or another we're going to have to bear more of this cost, and they don't want to do that. I actually can conceive a fair amount of enthusiasm for what we're trying to do here in Pennsylvania, which is to use the exchanges as the vehicle for covering these people. For one thing, if it's good enough for us, why isn't it good enough for them? This bifurcated system of a separate public insurance for poor people compared to everybody else, I think you wouldn't even have to be a sociologist to think maybe that's not your most favorite thing to do. Of course, it's going to cost more, but the question is whether we're willing to pay that. Now, that still doesn't solve the financing problem or explain why they won't take the money, but in a way it makes it look more Republican, and it also gives a chance for the state to have, in a way, by surrendering control over this, to have be less on a hook.
I mean, look, on the first point, that's their argument, that the feds, look, it's 100% federal finance for 3 years, then 90%. Blue governors in red states have offered to write laws which literally say, if it goes below 90, the program will be canceled. You could write a law that says, if it goes below 90, the program will be canceled unless 95% of the legislature supports reinstating it. You could write any law you want to credibly commit to that. So, that's not a great argument. Now, the other issue about Medicaid versus private, that's all a financing issue, like you say. I mean, literally, when we were writing the bill, a lot of people wanted to go Medicaid to 100, not 133. The only reason Medicaid to 133 was to save money. It's the only reason. I mean, well, the left liked it, but ultimately, it was about financing. Medicaid's cheaper because they don't pay docs well. And basically, that's why I just still don't understand this Arkansas solution, where they're somehow supposed to both put people in the exchange and have it be budget neutral. Yeah, that is literally impossible, mathematically impossible. So I don't understand what this Arkansas solution is. I agree, we could get lots of red states to sign on if we let them use the exchange, not all, but lots to sign on. But, you know, it's literally going to raise the cost of that group by on the order of, 25, 30%, and that's a lot of money.
Jim?
So I want to ask a sort of different question, because you both have danced around this. And so one of the things that that we know is that we can't trade health the way we can trade money. So the market sort of forces interest rates and generally on money to someplace, and everybody has to deal with those. But one of the problems we have in sort of how we look at the future is that we don't trade health that way. So we know that people have really high discount rates, and that may be one of the reasons why they don't buy health insurance. And behavioral economics suggests we can deal with that possibly by opt out rather than opt in rules and things like that. And I'm wondering what you're both sort of talking partly, each of you said at different points in your talk about sort of like, well, if we give people enough information, they'll make good decisions. But if they're making good decisions based on their discount rates and they're really high, they may not be things that we want them to do. So have you thought about how you think the ACA either dealt with some of those issues, or maybe how future adaptations or future things we as health economists might do and help that?
I mean, this is basically, to my mind, the single biggest, I love behavioral economics, but the single biggest problem is it's very hard to do welfare, which is basically, if people are making mistakes, what does the social welfare function look like? Yeah. And I think economists fall back on the social welfare function as still being an aggregation of individual preferences. And you're saying maybe not, and I agree, maybe not. The problem is a lot of people are afraid of opening those floodgates because it's not clear where it ends. I think a great example of this comes in an important area, which is wellness incentives in the law. So the law says that employers can now vary premiums by up to 50% to allow for wellness incentives. The problem is, where does discrimination end and wellness incentives start? So if I charge 50% more for my fat employees, is that wellness or is that discrimination? It's some of both. So kind of there's this really interesting issue about, so the law does allow some financial incentives to be used to try to affect behavior in sort of paternalistic way, but that runs into some other interesting issues that are hard to know how to resolve this.
So I don't have an answer for it either, but I think that's a big piece of that we don't know the answer.
Well, I'm more optimistic about both the problem and the solution. Most people did choose to buy private health insurance. Of course, there was a tax subsidy, but even so, the fraction that turned it down when it was available at a good deal was, this is what you get out of group insurance, generally less than 5%. So there are a few of them, and then the solution was, that was why I favored the individual mandate. Actually, the main reason was these few people who have very high discount rates, who don't think about the future, cut the crap, act like a grown-up and will make you do it. So I don't think that's either unsolvable, although there's obviously a limit to how far you can push it, as we talked about with the penalty in the individual mandate. But I think I don't know that I would regard most health insurance purchase, at least to me, the primary motivations are relatively short term. I mean, it's true there's preventive care and there's what's going to happen to me in the future. So I'm not sure I'd blame various kinds of anomalous perceptions, but I'm not sure I'd attach the discount rate. It's a imperfect perception of the discount rate as a reason for lots of other mistakes. But I think the failure to purchase health insurance, although it probably contributes to it, is probably related more to imperfect perception about the probability that something's going to happen to me.
I think we got time for one more question.
Okay, so I've seen a number of news stories saying that insurers, to bring their exchange rates down, are limiting their networks more than they previously had. Do you know the degree to which that's true, the degree to which it's a good thing, and whether there's likely to be public backlash against it?
It's absolutely true. I mean, that's the big innovation. They're not doing nearly as much with cost sharing as they are with network limitations. Good thing is the good thing for who? I mean, for the patients, it can't be a good thing. It might not be a bad thing. And the issue is sort of to what extent. Rob McKnight and I are doing some work right now where we've got the state of Massachusetts, for its public employees, put in a huge incentive to move to limited network plans. You got a 3-month premium holiday. If you move to a limited network plan, about 20% of employees moved over in one fell swoop for one group and not another. So it's a nice setup. And what we're finding is that the people went to specialists less, not to regular doctors less. that they ended up in the hospital emergency room less. We're not finding any observable effects on health. And so my sense is this may be a pretty, I don't think it's a long-run solution, but it may be more like a level shift, not a growth rate effect, but I think it's probably a sensible way to go, at least relative to purely open network.
I guess I have two comments on that. One is back to the actuarious dilemma that I was talking about. Well, at least if you're going to come in with a premium you're not sure of, if you have a limited network and you're
Right.
running out of money by October, you're probably in a better shape to stay within your boundaries, more so than if you have an unlimited network and you can't stop these people. The other issue is kind of has to do with the role of public policy here in choices. And I guess in some ways it begs the answer to your question, but if I saw a limited network and I was still convinced that access was reasonably good and these were good doctors and so forth, I'd be inclined to let that be offered. Maybe all public policy ought to do here is offer a set of options. We're sure none of them are terrible, they're all decent, and then leave it to people to make up their mind which of them they would prefer. But as a external observer, I don't care what insurance you have as long as you have some insurance that's reasonably decent, and that's not so hard to write rules to prescribe. So that'd be as far as I would go. I agree with John and Jonathan Abelok that it would be better to get people making good choices within that set, but in terms of what keeps me awake at night, that's probably not the most important one.
With that, I think we'll wrap it up, and will you join me in thanking Mark and John?